Soon we will start our teaching classes.
Yes, sir, start.
So I welcome you all once again to the teaching class of Department of Urology, Savai Man Singh Medical College, Jaipur. Today we have a presentation on IC BPS, interstitial cystitis bladder pain syndrome. This would be presented by our resident, Dr. RAGHAV KHURANA, and would be moderated by our faculty, Dr. AJAYRAJ HADA. So I request Dr. RAGHAV to kindly share his presentation.
Thank you, sir.
Your voice is a little, yes, be a bit louder. Yeah.
Am I clearly audible?
थोड़ा सा और जोर से.
Hello.
Yes, go ahead.
Good morning, everybody. Today I'll be presenting my seminar on bladder pain syndrome. Coming first to the definition, which many committees have given a definition, but the most favored definition is as given by Gibbs, which is pain or discomfort in the lower abdomen and or urogenital area of more than 3 months duration, which is the worst on full bladder, along with one or more lower urinary tract irritative symptoms like frequency, urgency, nocturia, which may be with or without standard pattern cystoscopy, provided other discernible pathology likely to cause these symptoms has been excluded. The AUA, EUA, and ICS have also given their definition. AUA says that it is an unpleasant sensation, pain, pressure, or discomfort perceived to be related to the urinary bladder, associated with the lower urinary tract symptoms of more than 6 weeks duration in the absence of infection and other identifiable causes. According to the EUA, it is the occurrence of persistent or recurrent pain perceived in the urinary bladder region, accompanied by at least one other symptom, which may be frequency, urgency, with no proven infection or other obvious local pathology. The ICS definition says it is the complaint of suprapubic pain related to bladder filling, accompanied by other symptoms such as increased daytime and nighttime frequency, and excluding proven urinary tract infection or other obvious pathology. There is an overlap of some symptoms with other commonly associated disorders, which may be overactive bladder or hypertonic pelvic floor dysfunction, urge incontinence, urgency, frequency, pain, and obstructed voiding. All of these can be seen in all three. Hypertonic pelvic floor dysfunction also has vulvodynia. The etiopathogenesis is multifactorial and which may act predominantly through one or more pathways, which result in a typical symptom complex. The possible etiologies include local bladder injury, infection, autoimmunity, allergies, neuromodulation, CNS involvement, ANS involvement, and crosstalk between the bowel and bladder, such as IBS, urinary toxins, and hormonal etiology. The normal bladder is as defined by this diagram. There is an epithelial cell which are bound together by intracellular adhesion molecules. Over that, there is an there is a glycosamine-glycan layer or a mucous layer, which has been shown that in the etiopathogenesis of IC BPS, this is damaged, thus leading to the various symptom complex. The irritating solutes such as potassium, they damage the glycosamine-glycan layer, causing inflammation and irritating the nerve endings which are supplying the epithelium, causing various symptoms such as pain, frequency, and urgency. Or the bladder insult may be caused by regional and widespread pain syndromes, immune-mediated autoimmune disorders, primary neurogenic inflammation, infection, bladder trauma, or genetic predisposition. All these lead to mast cell activation and histamine release, urothelial permeability changes, damaging the glycosamine-glycan layer, C fiber activation, the pain fibers get activated, and immunogenic and allergenic responses. These lead to progressive bladder injury, causing bladder pain syndrome, which may be positive with Hunner lesion, known as, or without Hunner lesions. The one without Hunner lesions has centralized pain with widespread pain syndromes and regional pain syndromes also. There's a unique pathogenesis which has not been identified for Hunner lesion interstitial cystitis. All these theories eventually lead to thinning of the bladder endothelium, high permeability, pinpoint bleeding, and bladder wall ulcer, which cause leakage of urine solutes into urothelium, increased NGF, IL-6, and histamine, and cause stimulation of CNS nociceptors, inflammation, hematuria, and pelvic pain. There are many associated disorders associated with bladder pain syndrome, few of which I'll be telling you, such as high tone pelvic floor dysfunction. It is identified by tender and hypertonic pelvic floor, and associated musculature can be found in approximately 80% of IC BPS patients. The symptoms overlap with IC BPS, making diagnosis more challenging. Etiology of hypertonic pelvic floor dysfunction is also unknown, and of IC BPS is also not very well understood, making it may date back to childhood voiding dysfunction. And there is a suggestion that there is a crosstalk through viscerosomatic and viscerovisceral neural pathways, which play a bidirectional role in the development of IC BPS and hypertonic pelvic floor dysfunction. Other associated disorders which have been associated with IC BPS are irritable bowel syndrome, fibromyalgia syndrome, sexual pain and dysfunction are commonly encountered in the female as well as male IC BPS patient. Vulvodynia, a condition defined as vulvar pain of at least 3 months duration without clear identifiable cause. Its prevalence ranges from 17% to almost all patients being affected. Chronic fatigue syndrome, allergies, and depression are also associated. Well-defined inflammatory diseases such as Crohn's disease, SLE, Sjogren's syndrome, and rheumatoid arthritis are infrequently seen but may be associated with IC BPS. The bladder-centric IC BPS patient is uncommon and it is usually associated with other diseases. There is no significant association with bladder carcinoma. Just to summarize what I said, regional pain syndromes, HTPFT, vulvodynia, IBS, widespread pain syndromes, fibromyalgia, CFS, autoimmune diseases such as SLE, RA, or IBD are all associated with bladder-centric pain and IC BPS. Reaching the diagnosis of IC BPS is very complex based on its definition and often confused with other disorders. Most challenging aspect is to exclude other identifiable and treatable causes of symptoms. The possible presentations of new patients are usually urgency, frequency, pain, and dyspareunia, whereas refractory patients may present with recurrent UTI symptoms, overactive bladder treatment failures, failed endometriosis therapy, and non-bacterial prostatitis in males. The differential diagnosis includes endometriosis, whose pain is worse during menses versus few days prior. Non-infectious cystitis, there may be history of radiation, NSAID use, cyclophosphamide, and or ketamine use. Vulvar disorders, pain occurs only during voiding, when urine contracts, vulva and or painful sexual intercourse. Overactive bladder, there is good response to antimuscarinics. Patient voids to avoid incontinence versus to relieve pain. There is no significant perceived bladder pain. Pudendal nerve entrapment is worse with sitting. Positional dependency suggests a neurogenic or musculoskeletal process. Prostate-related pain, pain during or after ejaculation, and pain on prostate palpation. Bladder pain is the central symptom of IC BPS. Urinary urgency, a sudden compelling desire to pass urine which is difficult to defer. As compared with overactive bladder with urgency, who fear urine loss, IC BPS patients often describe a compelling need to void, centered on mounting, not sudden pain, pressure or pelvic discomfort that occurs with filling of the urinary bladder. There is usually a low volume urinary frequency, and straining, which may be seen in high tone pelvic floor dysfunction, may also be present. Boston Area Community Health Survey found emotional, sexual, and physical abuse to be a risk factor or for symptoms suggestive of IC BPS. IC BPS is often associated with a decline in mental and physical quality of life, poor coping skills, anxiety, and depression. It is catastrophizing. Cognitive behavioral therapy may help. This we've already discussed. Natural history effects on quality of life. The two distinct phenotypes have been identified, those with pelvic pain only and pelvic pain and beyond. The latter group representing 75% of the patients. Pain beyond the pelvis had notably higher levels of sensory type pain, poorer physical quality of life, greater somatic depression, and more sleep disturbances. Flares varied widely in the term of duration, seconds to months, frequency multiple times per day to once per year or less. Symptom may be pain or urinary symptom, and intensity also varied. The most common length of flare was multiple days with increasing duration of flare associated with greater pelvic pain, urological symptoms, disruption to participants' activities, and bother. The flare onset may be related to sexual activity, which has been the only consistent factor associated with flare onset, and subpopulations appear to be triggered by various dietary factors and abdominal exercises. Various symptom scores have been established to identify baseline symptom severity, and to track response to therapeutic intervention. These are interstitial cystitis symptom index, interstitial cystitis problem index, the Wisconsin interstitial cystitis scale, pain urgency frequency score, and bladder pain IC symptom score. Physical examination in females, there may be anterior vaginal wall tenderness, there may be suprapubic tenderness, there may be associated pelvic floor dysfunction. Males present with suprapubic tenderness, sphincter spasm, and a tender rectal examination. Frequency volume chart is very helpful in monitoring therapy and to differentiate polyuria from classical small voided volumes expected with IC BPS. Daytime voids range from 17 to 25 to compared to 6 to determine the severity of storage symptoms, and it can be used to for positive reinforcement related to behavioral and pharmacological intervention. Investigations, a few basic investigations are always required. These include the urine dipstick test, urinalysis. These are the minimum required lab tests. If signs of UTI are suspected, culture sensitivity is added. Leukocytes alone in the urine do not rule out IC BPS. Testing for organisms such as chlamydia, mycoplasma, ureaplasma, corynebacterium, mycobacterium, and if sterile pyuria persists should be done. Urine cytology should be done if microscopic hematuria persists. And ultrasound of pelvic examination is the extension of pelvic imaging is always the extension of examination. Additional testing, we discussed urine culture, AFB culture, urine cytology, serum PSA. KCL testing has a historical value but not done nowadays. Anesthetic challenge test can be used to diagnose as well as a therapy. Laparoscopy may be used to differentiate with endometriosis. Imaging studies are used frequently, uroflowmetry and urodynamics. Imaging studies may help to differentiate between different walls and of the urinary bladder. KCL test, we inject intravesical KCL solution. Pain and provocation of symptoms constitute a positive test by sensory nerve provocation. Sensitivity and specificity is 69.5 and 50%, which were poor, adding no additional use over history and cystoscopy. And it does not correlate with either cystoscopic findings or bladder capacity on urodynamics. It is not a valid or recommended test any longer. Intravesical anesthetic bladder challenge, alkalized lidocaine test, instilling 10 to 20 ml of an anesthetic mixture of 200 milligram lidocaine mixed with 8.4% sodium bicarbonate into empty bladder. It is held for 10 to 15 minutes and then drained by a catheter. It can provide both relief to the patient as well as provide diagnostic information to guide future therapy. Routinely, UDS studies are not recommended, and 15% of patients diagnosed with IC BPS will demonstrate detrusor overactivity, and thus the coexistence of urge incontinence or detrusor overactivity should not preclude a diagnosis of IC BPS. The role of cystoscopy, it is not essential for diagnosis of IC BPS. It is cystoscopically in clinically diagnosed cases may be normal. It is definitely used to identify Hunner's lesions that reflect a severe disease and to objectively evaluate functional bladder capacity. To rule out bladder cancer or carcinoma in situ or different disease as compared to IC BPS. Just a few pictures showing what interstitial cystitis can look in cystoscopy. Mild IC, and we can see mild IC has just a few glomerulations and maybe an ulcer. Moderate IC is filled with glomerulations, and severe IC also shows ulcerations. A small video of cystoscopy with glomerulations and Hunner's ulcers. These pinpoint dilated vessels that we can see are glomerulations as seen on cystoscopy. These should not be present in the path of the cystoscope. These are the classical Hunner ulcers that can be seen with pinpoint hemorrhages. Hydrodistension. It is performed under GA and allows for stratification of patients into those with more classic disease associated with ulcers and glomerulations, and from those with no obvious mucosal abnormalities. The technique of hydrodistension generally involves gravity filling of the bladder at 70 to 100 centimeters of water for 2 to 3 minutes. This is a video of hydrodistension. Upon hydrodistension, there is a definite which shows bleeding from those pinpoint glomerations and ulcers, confirming the diagnosis of IC BPS. Bladder biopsies are routinely not recommended. Findings related to chronic inflammation are non-specific, and 30 to 40% of patients with clinical diagnosis of IC BPS may have a normal histology. It is indicated to rule out carcinoma in situ if suspected by a focal lesion or abnormal cytology. It may be considered in research trials. The microbiome and IC BPS have been an area of research. There are next generation sequencing techniques for the characterization of microbiota in asymptomatic healthy controls and female IC patients, showing differences in urine composition between different groups. Reduced microbial diversity is evident in patients with IC. Studies have showed low levels of Corynebacterium and high levels of Lactobacillus gasseri in the urine of bladder pain syndrome patients. Anti-proliferative factor may cause the epithelial thinning or ulceration seen in interstitial cystitis. Urine APF may be useful as a diagnostic marker and as a disease parameter for treatment studies. Agents that inhibit APF production or activity may potentially be useful for the treatment of interstitial cystitis. Other markers which have been studied are TAM-Horsfall protein, IL-8, CXCL1 and 10, which are chemokines, NGF, sialic acid, HBEGF, GB51 nitric oxide, IL-6, histamine, methylhistane, and neutrophil elastase. These are all being studied and no one has shown a definite diagnostic value. A proposed diagnostic algorithm for evaluation of interstitial cystitis or bladder pain syndrome. Once it is suspected, a detailed history and physical examination should follow, including urine analysis, urine culture. Cytology in older patients with smoking history. A post-void residual urine will help. Voiding diary definitely helps to diagnose as well as monitor therapy. A symptom score and or pain scale may be used. We then evaluate for confusable conditions such as UTI, overactive bladder, high tone pelvic floor dysfunction, constipation dominant IBS, vulvodynia, vulvodermatosis, endometriosis, ketamine cystitis. Once we suspect complicated IC BPS, which has incontinence, retention, microscopic or gross hematuria, pyuria, or neurological disease, then we consider cystoscopy, cytology, imaging studies, UTS, laparoscopy, and a specialist referral. Or a confusable disorder is present, then we reassess and treat all those disorders. Uncomplicated IC BPS, we can straight away start with the beginning empirical therapy. There are various challenges in management of an IC BPS patient. The management has been controversial. There are over more than 200 therapies which have been said to have benefit. There are few well-defined studies which exist. Evidence of all these studies which have been done are inconclusive. The syndrome presents with varied manifestations and the treatment is not generalized. The principles of clinical management are as follows. The treatments are ordered from most conservative to least conservative. Multiple simultaneous treatments may be considered if in best interest of patient. Pain management should be considered throughout the course of therapy with the goal of maximizing function and minimizing pain side effects. The diagnosis should be reconsidered if no improvement within a clinically meaningful time frame is there. The tiered therapy that has been proposed is as such. The first line treatments are general relaxation, stress management, education plays a vital role, self-care, behavior modification, and pain management. Second line treatments include specialized manual physical therapy, oral agents such as amitriptyline, hydroxyzine, cimetidine, and pentosan polysulfate. Intravesical therapy such as DMSO, heparin, and lignocaine. Pain management. Third line treatments include cystoscopy under anesthesia with hydrodistension, treatment of phonolesions if found, pain management. And fourth line treatment is intradetrusor botulinum A toxin, neuromodulation, and pain management. Fifth line treatments, cyclosporin A and pain management. Sixth line include surgery, which may be urinary diversion with or without cystectomy, and substitution cystoplasty. We must note that pain management is included in all the tiers and should be of utmost importance. Management of bladder pain syndrome and interstitial cystitis, it begins with conservative therapy, oral therapy, intravesical therapy, sacral neuromodulation, Botox injection, and lastly, surgery. Conservative management includes education, counseling, stress management. Behavioral modifications include controlling fluid intake, a timed voiding with voiding diary, physiotherapy, soft tissue massage, and biofeedback, analgesics, sex counseling, dietary modifications such as reducing coffee, tea, chocolate, carbonated beverages, alcohol, citrus fruits and juices, spices, or artificial sweeteners, or identifying a particular dietary thing that causes a particular symptom in a patient. Oral therapy, we can start with amitriptyline, starting with 10 to 100 milligram or increase to 300 milligram per day. Analgesics, antihistamines such as hydroxyzine, anti-inflammatory agents, and anticholinergics. Anticonvulsants such as gabapentin have been shown to have benefit. Cimetidine, immunosuppressive agents such as cyclosporin. Pentosan polysulfate sodium forms the cornerstone of therapy in some regimens. Now, we will see where all these act. The repair of epithelial dysfunction is very important, such as we need to modulate the neural activity and stabilize the mast cells. So for repair, we use pentosan polysulfate. To modulate the neural activity, we use tricyclic antidepressants such as amitriptyline, and stabilizing mast cells, we use antihistamine therapy such as hydroxyzine. Overactive bladder symptoms, we can use anticholinergic agents such as sulfenacin or oxybutynin. Intravesical agents which are used commonly are chondroitin sulfate, sodium hyaluronate, dimethyl sulfoxide. Cocktails have been shown to have proven efficacy for a longer period of time, these cocktails are instilled once weekly for 6 weeks, and there is 50% objective response rate. The cocktails commonly used include sodium bicarbonate, heparin, triamcinolone, and bupivacaine or lignocaine. Various cocktails have been proposed, and all of these stabilize the bladder epithelium and glycosamine glycan. Other therapies such as sacral neuromodulation and intradetrusor botulinum toxin have also been used. Surgery is usually a last resort, which can be done by bladder augmentation, urinary diversion, or cystectomy. There are various emerging therapies which are coming up but lack evidence. Hyperbaric oxygen, PDE5 inhibitors, N-acetylcysteine, monoclonal antibodies against TNF-alpha, and cannabinoids, intravesical liposomes, intravesical adalmitrol, tacrolimus, transcranial magnetic stimulation, adalimumab, and botulinum toxin in levator and eye muscles. Now, this is a proposed algorithm that we follow in our own hospital, that is the Department of Urology SMS. When patient presents with pain, frequency, urgency, or nocturia, a detailed history, physical examination, a frequency volume chart, a urine routine examination, and ultrasound is performed. If the results are uncomplicated, if the results are straightforward, then the patient is diagnosed as an uncomplicated IC BPS patient. If the results are complicated or equivocal, there may be pyuria and urine culture. There may be sterile pyuria, which is followed up with AFB culture. There may be hematuria, which is followed up with urine cytology, or drug-induced or query endometriosis, which can be confirmed on laparoscopy or imaging. The voiding dysfunction, which is then followed up with uroflowmetry and urodynamics. Lower urinary tract pathology, cystourethropy is must. Once a patient is labeled as uncomplicated IC BPS, a cystoscopy is done to differentiate between Hunner's IC and non-Hunner's BPS and others. Others include other pathology. In a patient of Hunner's interstitial cystitis, we go ahead with hydrodistension, fulguration, dissection, and injection of triamcinolone. Followed up with conservative pharmacotherapy, IV intravesical instillation of cocktails, pain management, followed with neuromodulation, botulinum toxin injection, and cyclosporin. Lastly, if all these fail, then we go ahead with augmentation cystoplasty or cystectomy. If we suspect other pathology, then we treat and evaluate for the other pathology. In non-Hunner's bladder pain syndrome, which is often associated with fibromyalgia, allergies, IBS, migraine, chronic fatigue syndrome, and rheumatoid arthritis, the further treatment is based on the symptom phenotype and degree of quality of life impairment, patient preference, availability, and adverse event profile. What is must is education in all patients, dietary modifications, and sexual counseling. In urinary predominant patients, we advise them bladder training with a voiding diary. Anticholinergics are advised, intravesical agents are administered, and Botox and neuromodulation is done. Psychosocial stress management and support, yoga, meditation, which have been shown to have a great improvement in symptoms. If organ-specific IC-BPS is identified, then we go ahead with amitriptyline pentosan polysulfate or intravesical cocktail injection and botulinum toxin. Infection is always to be treated with antimicrobials. Neurologically, if patient has neurological prominent symptoms, we go ahead with gabapentin, hydroxyzine, and neuromodulation. Tenderness or severe dyspareunia may be treated with pelvic floor physiotherapy, massage, acupuncture, and trigger point injections. And this is the summary of bladder pain syndrome and the algorithm that we follow in our hospital. Now, coming for a few questions. A 45-year-old female with IC-BPS presents with dyspareunia, constipation predominant IBS, urinary hesitancy, and the need to strain with urination. Which therapy is the least likely to be helpful? Physical therapy, behavioral modification, neuromodulation, chemodenervation of the bladder, or skeletal muscle relaxants? So chemodenervation of the bladder has been shown to be the least likely helpful in such a symptom complex. Which of the following has the least in common with IC-BPS? Vulvodynia, chronic bacterial prostatitis, or myalgia?
Any issue?
No, sir.
Raghav,
Yes, sir.
are you over?
Yes, sir. Next are MCQ, sir.
You can start with MCQs. Yes, go ahead.
Okay, sir. Okay, sir. Okay.
So starting again with a multiple choice question. So 45-year-old female with interstitial cystitis bladder pain syndrome presents with dyspareunia, constipation predominant IBS, urinary hesitancy, and the need to strain with urination. Which therapy is the least likely to be helpful? Physical therapy, behavioral modification, neuromodulation, chemodenervation of the bladder, or skeletal muscle relaxants? The least likely to be helpful is so chemodenervation of the bladder. Which of the following has the least in common with interstitial cystitis bladder pain syndrome? Vulvodynia, chronic bacterial prostatitis, or myalgia, penile pain, perineal and scrotal pain?
Chronic bacterial prostatitis.
That's correct. So chronic bacterial prostatitis has the least in common with IC-BPS. The only phenotype of IC-BPS currently shown to have a unique response to therapy and different natural history is nocturia, daytime frequency, absence of bladder plane, glomerulation or Hunner lesions.
Daytime frequency.
So Hunner lesion which has been shown to have a unique response to therapy. Amitriptyline's potential beneficial effects for IC-BPS patient include all of the following except its ability to promote sleep, its anticholinergic effect, its antihistaminic effect, its effect on neuropathic pain, and its antidepressant effect.
Its ability to antidepressant effect.
Antidepressant effect is shown less benefit as compared to the others. Which test is potentially most helpful for prognosis and therapy? Potassium chloride test, intravesical heparin trial, cystoscopy and low pressure bladder hydrodistension, bladder biopsy or urodynamics?
Potassium chloride test.
Cystoscopy and low pressure hydrodistension. Which of the following intravesical treatments has shown proven efficacy for IC-BPS in pivotal US FDA administration trials? BCG, lignocaine, botulinum toxin, heparin, or none of the above?
None of the above.
It's none of the above is actually pentosan polysulfate, which has shown good efficacy. That will be all from my side. Request, share.
Yeah. Come here. Thank you, Raghav. So I would request my residents and faculty and all those who might have joined us today, if they have any query, question, or comment to make, please let me know. Today I'm not feeling that well, so there's little change in the whole program. But anyway, if there is any, Dr. Nachi, if you have anything to make, a question or any comment. So briefly, today we could not get the expert also for some reason. But anyway, IC BPS is a very kind of a interesting problem in the sense that many people do not understand this problem. And unless you understand the problem, you would not be able to diagnose or recognize cases in the OPD. So it is still a disease which is, we do not know the exact etiopathogenesis. There are various etiologies which have been hypothesized, which include chronic infection, chronic trauma to the bladder, autoimmune disorder, allergic disorder, genetic disorder, change in the urinary microbiome, that is urinary dysbiosis. So there are a lot of things which have come up, which probably can result. So basically, it causes some defect in the gag layer of the bladder mucosa that results in these toxins present in the urine to enter into the bladder wall, which causes inflammation and inflammation of the whole bladder wall, causing interstitial cystitis. So that's the basic pathology, and we all know it is basically a syndrome and not a disease. So whenever the patient comes with urinary symptoms like urgency, frequency, nocturia, which is associated with pain, particularly a pain which is either in the suprapubic region, pelvic area, and which is very characteristically, which increases when the bladder gets filled up, and it's more extreme on full bladder. And the patient usually gets relieved partially or completely after voiding. So that is very typical of IC BPS. And we all know it may be confused with many other confusable disorders, which includes various other urinary problems, gynecological problems like endometriosis, vulvodynia, urinary problems like stone disease, like malignancy, and so even prostatitis. So we have to actually diagnose it or investigate it in case the things are confusing. So if the patient, so the basic investigation is a urine routine microscopy examination or a dipstick test. So if the dipstick tells you that there is nothing in it, it's completely normal, and on history and physical examination, you do not find any other kind of positive finding, then it becomes a case of IC BPS, and if the patient is suffering from this problem for at least 3 months. So from by Gibbs definition, it is 3 months. By AUA, it is 6 months. So if the symptoms are there for 3 to 6 months and you do not find any other problem and the urine routine is normal, you diagnose it as IC BPS. If there is some problem on history and physical examination, or the urine shows pyuria or hematuria, then you definitely have to try to rule out the other causes that we call equivocal cases or complicated cases. And if it is a clear-cut case of IC BPS, then in our department, we always follow doing a cystoscopy. We have done studies in that. We have presented it in various forums also, and it has shown that if
you diagnose Hunner's lesion in the initial investigation, definitely it will help in the management of the patient. So cystoscopy is basically done to differentiate between Hunner's IC BPS and non-Hunner's IC BPS, and also to rule out some other confusable disorders which may be present in the bladder, like malignancy, carcinoma in situ, bladder stone, etc. And it also tells you about the bladder capacity, also how the patient is going to face.
Now, after raining, that room temperature got relieved.
Pardon?
You feeling the room temperature now good?
Is there, Nimeshji, is somebody asking a question or there is a interruption? So if there is interruption, please mute him.
No, somebody is asking, Dr. Shahnawaz.
Dr. Shahnawaz. Yes, Dr. Shahnawaz, please unmute yourself and just go ahead. Okay. So I would request all those who might have joined us to unmute themselves and go ahead with their questions. Anyway, so we were there. So in patient, so cystoscopy, we do usually as the initial investigation to differentiate between Hunner's and non-Hunner's IC BPS. And if it is a Hunner's IC BPS, then definitely we have to go ahead with doing a hydrodistension, fulguration, resection, and injection triamcinolone, etc. And these patients would require a very close follow-up in the sense that they would require intravesical installations, bladder training, and later, some of these patients may still require surgical therapy. If it's a case of non-Hunner's IC BPS, then usually we go ahead by phenotyping these patients. There are various phenotypes like the U-point phenotype, where we try to find out which symptom is predominant, whether it is a urinary symptom, whether it is a psychological symptom, whether it is an organ specific, whether it is a neurological main symptoms, or it is a pelvic tenderness or the pelvic floor muscle problem. So based on that, we will try to manage these cases. So that is very important because all patients are different and they need to be phenotyped before we start the management. So this was in a nutshell about the IC BPS. If anybody has any question, or then let me know. Dr. Shahnawaz, do you have any question? Dr. Ejaz Ahmed has unmuted. Can you go ahead, Dr. Ejaz? Any faculty or resident has any question regarding IC BPS? Yes, go ahead.
Once we label a patient case of IC BPS, so we go for the staged management from first time to second. So in between changing the treatment plan, if the patient develops some other symptoms, we again have to investigate the routine microscopy and cystoscopy, or should we straight away go for the next line of management in between? Because he may have developed a bacterial afterwards, he may be on IC BPS years, but later we have developed some other pathology, but we are biased with that diagnosis.
Yes. So the question is, if suppose the patient is on the treatment of IC BPS and develops some problems which may not be related to IC BPS, should we go ahead and treat according to IC BPS? Or definitely yes, these patients may have other problems also. So definitely we should keep it in mind that if in case this patient has any other problem, like we have seen that many patients do have urinary tract infection, IC BPS, and that can actually cause a flare phenomenon in IC BPS, and they require a short course of antibiotics also. Though long-term antibiotic therapy is not indicated in IC BPS, but definitely to reduce the flare phenomenon, we need to give antibiotics. So we have to do a urine routine examination and culture to confirm the infection and give a short-term antibiotic therapy. Yes, there was somebody who wanted to say anything. Any other question? So definitely you have to kind of, as I said, you cannot be dogmatic that this patient is IC BPS only, and you have to treat on that line only. So you have to be very vigilant that this could be other problem also. So once you start the treatment and the patient is not responding to the therapy, you should go back and again try to see whether on the history, physical examination and investigation, you are missing something or not. And then you have to treat accordingly. Yes. So if nobody has anything to comment on, so we would wrap up this session. Dr. Ajay, would you like to? So I would ask the moderator to kindly come and give his last remarks and wrap up the session.
Thanks, Dr. Raghav, for the wonderful presentation, which consists of all important points. And I would like to thank our mentor, guide, esteemed teacher, CM sir, for enlightening knowledge and imparting us the knowledge. Thank you, sir.
Thank you, everybody, and have a good day.